Continue. Very well, thank you. Well, good afternoon, everyone. Thank you for attending this European Association Psychological Assessment digital event. First of all, let me introduce myself. My name is José Antonio Piqueras. I'm from the University Miguel Hernández of Elche in the south of Spain. I belong to the executive committee of the EAPA, and I will be the moderator of the 3 sessions this afternoon. Let me remember that in order to improve communication, please remember to switch off microphones during the speaker's presentation or when other colleagues are speaking. Everyone is doing it, so no problem. We are aware you can attend the 3 digital events or only some of them, but anyway, let me briefly explain what was our rationale when we designed this digital event on clinical psychological assessment, briefly. To be honest, when we planned this digital event focused on clinical psychological assessment, we asked 3 leaders in new approaches to this discipline for a participation. We were, and now we are aware that these approaches are neither exclusive or nor exhaustive, because we would have been happy to address other classicals such as ICD-11-based assessment and other innovative models such as hierarchical taxonomy of psychopathology, network analysis, applied to the field of psychopathology, etc. Anyway, today's theoretical approaches seem to us to be novel and useful approaches for the clinician and researcher in clinical psychology. Our expectation is that these lectures will be good conceptual introductory lessons to Transdiagnostic model-based assessment, DSM-5-based assessment, and finally, a more integrative view, including strengths and positive variables, such as the new Power 3 meaning framework. We hope they will be of interest to you. Okay, and now let me introduce the first expert. Hello, Andrew, good morning for you there in Boston. And thank you for getting up early. And thank you for being on board. Andrew Curreri belongs to the Transdiagnostic Treatment and Research Program Center for Anxiety and Related Disorders in Boston University. He belongs to the research group headed by David Barlow, one of the most known researchers on transdiagnostic model. Curreri works at the Transdiagnostic Treatment Lab. He is interested in understanding mechanisms of change in cognitive behavioral therapies with the goal of optimizing treatment delivery based on individual patient characteristics. He is also interested in non-specific treatment factors such as expectancy, adherence, and therapeutic alliance. The title of his keynote is, as you can see, Case Formulation and Clinical Assessment using a Transdiagnostic Framework. That's all by me. I'll leave you with Andrew Curreri. We'll have a short question and answer period at the end. Now is your time. Enjoy the speech, everyone. Thank you.
Thank you so much, Jose. I appreciate the introduction. Yeah, so good afternoon, everyone. Good morning for me. So I'm over in Boston right now. So it's 9 o'clock on Monday morning and a beautiful time to be here presenting at the conference. So my name's Andrew Curreri. I am a 5th-year graduate student at Boston University, and I work in Dr. David Barlow's lab, where we focus our work on better understanding how we conceptualize and how we treat emotional disorders from a transdiagnostic perspective. And so I'm really excited to be here today to talk about case conceptualization and assessment from this transdiagnostic perspective outside of the boundaries of a more categorical diagnostic system. So I want to start by describing categorical approaches to psychological classification, the limitations of those approaches, and the advantages of more transdiagnostic alternatives. And then I want to share the transdiagnostic case formulation tool that we use in my lab to better understand our individual patients within this perspective. Then we can talk about how we would go about assessing each component of that case formulation. And then finally, if there's time at the end, which there may be, we can talk about how we apply that assessment to treatment. So I wanted to start by giving a brief background on the development of the DSM, at least in America. just to give a little bit of context around the forces that have given rise to the desire to think about things in a different way. So before 1980, mental disorders were conceptualized in these broad categories like neurosis or psychosis that were largely based on psychodynamic theories around the etiology of psychological distress. But in 1980, the DSM-3 came out, and that marked a really major shift in the way that we were thinking about mental disorders. So in DSM-3, they abandoned the emphasis on etiology and instead focused on observed or expressed symptoms of different disorders. And so that new focus improved diagnostic reliability because clinicians could more easily come to agreement around what diagnosis to give based on just doing a symptom count. But what we've seen over time with subsequent versions of the DSM, so DSM-4 in 1994, and then DSM-5 most recently in 2013, we've seen the rise of what we call splitting, which is basically slicing psychopathology into narrower and narrower categories. And what we end up with that approach is a greater number of different diagnostic labels that we can use to describe what are ultimately, in many cases, just minor variations of a very similar syndrome. And there's really no shortage of commentary around the limitations of the DSM specifically, or the ICD, or just any sort of categorical approach. But I wanted to highlight a few key limitations that have prompted, I think, most interest in developing an alternative framework. So the first is overlap in symptoms across different disorders. So take, for example, generalized anxiety and major depression, two different disorders, but they share some symptoms in common: fatigue, difficulty concentrating, sleep disturbances. We see the same thing with depression and PTSD, post-traumatic stress disorder, where there are symptoms in common like negative beliefs or difficulty experiencing positive emotions, or cognitive issues like difficulties with concentrating. And so having these symptoms in common across different diagnoses presents a challenge to clinicians who want to reliably diagnose individuals who might present with a range of different symptoms. What we end up with is essentially a system where two people could have different diagnostic labels, but could actually look fairly similar symptom-wise. Another limitation of a categorical system is actually the exact opposite problem, where two people with the same diagnosis could look very different. They could experience very different symptoms. My favorite example of this to give is a paper from 2013 by Isaac Gallitzer-Levy, and the title is just, "There are 636,000 ways to have PTSD." And that's just based on an analysis of all of the different combinations of symptoms that somebody could endorse across the 4 PTSD symptom clusters and get the label of PTSD. Ultimately, we see that two people with that same label can look very, very different from each other. We see that in depression too. So to meet criteria for depression in the DSM, you need to meet 5 of 9 symptoms. So any two people with depression could only have 1 symptom in common and then 4 non-overlapping symptoms and end up with the same diagnosis. The math works out the same way for borderline personality disorder. So 5 symptoms out of a possible 9. So any two people could only share 1 symptom in common, but still end up with the same label. And this really begs the question of how useful these labels are when there's so much wiggle room in what could fall under each one. I also wanted to talk about comorbidity. At our clinic in Boston, the Center for Anxiety and Related Disorders that Dr. Barlow founded, it's really the rule rather than the exception that people who are seeking treatment are going to meet diagnostic criteria for more than one disorder at the same time. Or if they only meet criteria for one disorder now, they're very likely to have met criteria for a different one in the past, or maybe will in the future. So for example, those of us who work clinically might recognize that a lot of folks with depression also report significant anxiety. A lot of people with PTSD also report maladaptive substance use. And seeing these patterns play out in such a common way implies that there might be some shared etiological processes or shared maintenance factors underlying multiple seemingly distinct disorders. Finally, in DSM-4, there's a category called not otherwise specified, which is now called other specified in DSM-5. So within the anxiety disorders, if somebody doesn't meet criteria for an established anxiety disorder, they could get the diagnosis of other specified anxiety disorder. The same system exists for depressive disorders, for trauma and stressor-related disorders, etc. And those categories exist to capture clinically significant distress or impairment in people who don't meet the symptom threshold for any other diagnosis. But just the existence of these categories sort of implies that the symptom thresholds or the boundaries between different disorders might be somewhat arbitrary. So the transdiagnostic approach offers an alternative that accounts for some of the limitations of the categorical approach. Conceptualizing psychopathology transdiagnostically involves focusing on the core commonalities across disorders rather than the symptom-based differences. And so when you approach treatment transdiagnostically, you want to focus the treatment on these shared mechanisms, which are the shared underlying psychological processes that cut across disorders. Approaching clinical assessment without being attached to diagnostic categories really opens us up to a different understanding of psychopathology. And so when you start treatment with somebody, you want to conceptualize their case and do some assessment around what those shared mechanisms might look like, because in some ways that may end up actually being more important than the differences between the specific symptoms that they're endorsing. So this is the functional model that my lab uses to conceptualize emotional disorders by focusing on those underlying processes that give rise to the symptoms of different disorders. And I will say we used to have a much simpler diagram, but I made this one for a publication that's in press right now at Current Directions in Clinical Psychology. And this is the first time that we're presenting it. So I hope that it's clear, and certainly there's time at the end for questions and answers around it. But I do want to walk us through this functional model because it lays out the context for how we choose to understand psychopathology a little bit differently. So we can actually start going through this in the middle by looking at neuroticism. So neuroticism is the core underlying factor that sets the stage for the development of emotional disorders. And we would conceptualize neuroticism as consisting of two facets. So first, there's a genetic or biological predisposition to feeling emotions frequently or intensely. And then the second facet is what we call aversive reactivity to emotional experiences, or the perception of emotions as uncontrollable or intolerable. And so everybody exists somewhere on both of these dimensions. Everybody has some genetic contribution to their emotional sensitivity, and everybody has some perceptions of their emotions. For some people, emotions could be perceived as intolerable or unacceptable. For others, maybe less so. It's those individuals who are higher in neuroticism, meaning they have a greater genetic contribution to sensitivity and a greater sense of aversion to their emotions, that can then go on to develop emotional disorders, as we see in the cascade on the top right of the figure. So when a strong emotion is triggered, individuals who are high in neuroticism tend to engage in what we call emotion-motivated avoidant coping. And that's any effort to avoid or suppress or escape their emotions. Some folks just refer to that process as avoidance. People who are psychodynamically trained might be familiar with the concept of defense mechanisms, and that sort of aligns with this concept as well. And when engaging in avoidant coping can lead to short-term relief because there's some distance from that uncomfortable emotion. But in the long term, it can create problems in the person's life, and it could end up reinforcing these beliefs that an emotion shouldn't be experienced or can't be tolerated. And so in our view, that's really the central cycle that maintains all emotional disorders. And so that's the functional mechanism that we want to be targeting in treatment. On the bottom line, just for the sake of contrast, we can see how this process plays out for folks who are lower in neuroticism. When emotions are occurring less frequently and they're judged to be acceptable or controllable or tolerable, people are more likely to just ride the wave when the emotion comes up, and the emotion tends to dissipate on its own without adversely impacting somebody's behavior. We can also briefly take a look at the left side of the diagram, which shows the development of emotional disorders based on learning experiences. So essentially, for some folks with neurotic temperament, strong emotions tend to coalesce around a particular focus or a particular trigger, like loss in depression or judgment and evaluation in social anxiety disorder. And I'll talk a little bit more about exactly what that looks like soon. So I know I just went through this complicated figure with a lot of boxes to describe this functional model. And what I'll do now is just tell you that these 3 points here are really all that you need to remember about the case formulation. So we can whittle it down to just these 3 steps of understanding how your patient experiences frequent and intense negative emotions, aversive reactivity to emotional experiences, and emotion-motivated avoidant coping. This is where all of the really rich individual differences that are going to be relevant in therapy will come into play. And using this lens, we have the freedom to explore more of our patients' experiences than just what the DSM captures. So what I'll do now is I'll go through step 1, 2, and 3 just to describe more in depth what we mean by each of those. And then I'll go back and we'll talk about how we would assess each of those levels of the formulation. So first is the experience of frequent and intense negative emotions. As I described before, that's a core feature of the neurotic personality temperament, and there's usually a genetic or biological contribution to emotional sensitivity. As I described before, intense emotions can coalesce around a particular focus or a particular trigger, and that can occur through learning processes like classical conditioning or observational learning. So take panic disorder, for example. There are a lot of people who experience non-clinical panic attacks, but then don't go on to develop panic disorder. It's the individuals who are higher in neuroticism, we believe, who could experience a first panic attack, and that could cause an association between physiological arousal and the emotion of fear through the process of classical conditioning. Thus, fear can emerge really strongly or really intensely when somebody notices internal sensations in the future, and that could lead to avoidant coping that could give rise to the cycle of panic disorder. Similarly, a lot of people with generalized anxiety recall that their parents were warriors when they were growing up. And so worry was modeled for them as a response to anxiety or uncertainty. So for people who are higher in neuroticism, that could predispose them to worry in response to uncertainty or anxiety about the future in their own lives. So those are just a couple of examples of how learning processes can cause particular emotions to coalesce around particular triggers and set the stage for different disorders. And you might have noticed that when I went through those examples, I was giving them using specific diagnoses. And that's because, at least in part, the different emotional disorders in the DSM are distinguished from each other by the type of trigger, but otherwise share a lot of features. The second step I want to describe is what we call aversive reactivity to emotional experiences. And that's the sense of uncontrollability or unpredictability around negative emotions. I would actually describe it as almost like a belief system. So it's like a limited self-efficacy to be able to influence important events or cope with important events. And this can manifest in the form of different vulnerabilities that have been described in the research literature, things like anxiety sensitivity, experiential avoidance, intolerance of uncertainty, and distress intolerance. And there could be more constructs like that we haven't coined a term for yet. And in many ways, those constructs overlap a little bit with each other. But those are just useful heuristics for understanding different ways that people might respond with a sense of aversion to their emotions. So let's get some examples of how these can look from a transdiagnostic perspective. So first, anxiety sensitivity is essentially a sense of distress or aversion that can come about after experiencing interoceptive or physiological sensations that are associated with strong emotions like anxiety. And in the literature, anxiety sensitivity is typically associated with panic disorder, which makes sense. Panic is a very physiological manifestation of anxiety. But we would actually argue that anxiety sensitivity is a transdiagnostic construct and warrants some attention across the range of emotional disorders. So let's look at how that can look different in different disorders. For somebody with panic disorder, anxiety sensitivity could manifest with the thought, if my heart beats any faster right now, I might have a heart attack or a panic attack. But it could also manifest in social anxiety with the thought, if my face flushes in front of people, everybody's going to know that I'm anxious. It could also manifest in illness anxiety disorder with, I'm feeling a sensation right now, and that might mean that I'm terribly ill. So depending on what the focus of anxiety is, having anxiety sensitivity could prompt the development of different symptoms, all rooted in aversion to physiological sensations. Another example is intolerance of uncertainty, which is a sense of distress around not being able to know something important with certainty. Again, tends to be associated in the literature in a diagnosis-specific way, so with OCD or with GAD, but intolerance of uncertainty can also manifest across the range of emotional disorders. With OCD, that could look like the thought, I think I locked the door, but what if I didn't? With GAD, it could look like the thought, so many different things could go wrong on this trip, and then engaging in the worry process of trying to think through what those all could be. In depression, intolerance of uncertainty could come up, and it could look like the cognition, what did I do to deserve this? Or what did I do to cause this loss? And then that could prompt the ruminative cycle of trying to think through all of the different reasons for causes or consequences of something that happened in the past or is happening in the present. The reason that aversive reactivity is problematic isn't just because they're associated with increased distress, but also because they tend to be the reason driving people to engage in avoidance. So if you have social anxiety and you're high in anxiety sensitivity and you're worried about how your face flushing might look to other people, that might cause you to avoid a situation in which people might see your face flushing. Similarly, in OCD, if you're having a thought about wondering whether or not you locked the door and you're really high in intolerance of uncertainty, you might be more likely to go check on the door. And in both of those cases, those lead to the cycle of those respective disorders. So in that vein, let's talk about that third step, which is emotion-motivated avoidant coping. This describes any behavioral or cognitive strategy that's meant to reduce or avoid emotional discomfort. And this is probably the most idiosyncratic category out of the three, where there are just as many avoidance strategies as there are people who struggle with emotions, because it looks different from person to person. But across all of them, there's a similar pattern that emerges around reinforcement and impairment that plays out in the short and in the long term. So in the short term, avoidant coping tends to lead to relief from emotional discomfort and or a false sense of control or certainty around a situation. But in the long term, what we see is that avoidant coping behaviors might be inconsistent with somebody's goals or with their values. And the more we rely on avoidant coping that's motivated by getting rid of an emotion, the less we give ourselves a chance to disconfirm maladaptive beliefs about what it might look like to actually ride out or fully experience or process that emotion. So I'll go through a couple examples here as well. So avoidant coping can manifest on the level of behavior or cognition. So behavioral avoidance can look many different ways. It could look as obvious as completely avoiding a trigger situation. I'm not going to give that speech, or I'm not going to go into that public place because I want to avoid this emotion that I'm anticipating from coming up. It can also look like actively engaging in a different type of behavior, like a maladaptive coping behavior, like substance use or alcohol use or binge eating. And we would consider those to be emotion-motivated avoidant coping if the primary motivator for those behaviors is to get rid of an uncomfortable emotion, to distract from it, to push it away, or to suppress it. Finally, behavioral avoidance can look as subtle as just carrying a security item or a safety signal with you. That could be like bringing a safety person to a party so that you feel comfortable there. It could look like wearing your lucky socks on an airplane ride if you're afraid of a panic attack on the plane or the plane crashing. Like I said, avoidance can also manifest in cognitive activity. So repetitive negative thinking, like worry and rumination, are examples of avoidant coping, where usually there's something that's being avoided as people engage in processes of worry and rumination. Similarly, distraction and thought suppression are different ways of deploying attention so as to reduce contact with an uncomfortable emotion. So if we're going to go about treatment from a transdiagnostic perspective, it requires us to assess and understand those functional mechanisms that are underlying comorbidity. So we would recommend getting started with assessment of this functional model in the first session of treatment, and to continue to assess these things in an ongoing manner as more and more information is going to come up as you get to know your patient better. And we recommend monitoring symptoms just to get a sense of the way that things are changing over time as you're engaging in therapy. So now I'll go through recommendations for assessment for each of those three levels. So the first is frequent and intense negative emotions. You want to get a better sense of your patient's subjective experience of negative emotions. How intense are they? How frequent are they? How long do they last? In what contexts are they most likely to occur? And you want to evaluate the extent to which their emotions are perceived to be excessive or inflexible. Is the emotional response consistent with what's needed in the situation, or is it consistent with their goals or their values? One benefit to this focus on emotions rather than symptoms is that there's now space for us to assess and treat issues that are relating to emotions that might fall outside of DSM or ICD categories. So for example, anger is really common in anxiety disorders, but doesn't really appear very often in the DSM. And so if you're working from a really categorical symptom-based framework, you might be missing a really important piece of the puzzle by not assessing a broader picture of what your patient's emotional experience looks like. So these are just some examples of questions that you can ask. We would recommend, because of how idiosyncratic this model is, we would recommend sort of like a looser clinical interview around some of these things rather than a self-report scale. So to assess for negative emotions that are frequent or intense, you can go with your gut, you can have a collaborative discussion, but a couple questions we might recommend could be things like, does it seem like you feel certain emotions more than other people? Is it hard to stop thinking about things that bring up those emotions? Have other people observed or commented that your emotions seem to be more intense than others in response to particular situations? Does it take you longer than other people to calm down when you get upset about things? Questions like that can lead to really good information around that first step of the formulation. For the second step, we're looking at aversive reactivity to emotional experiences. So that's when emotions are seen as being aversive, or they're unwanted, or they're judged to be bad. And so you can be on the lookout for how your patient is talking about their emotions as you're going about the therapy session. They might report that, over the last week, I felt really anxious about something, and I just kept thinking to myself, this is really bad. I shouldn't be feeling like this. It's wrong or weak or stupid for me to feel this way. And all of those judgments are manifestations of that aversive reactivity, and that's all going to be good information for you to keep in mind as you conceptualize their relationship with their emotions at the start of therapy. In some ways, we actually would recommend using self-report scales to get at aspects of this step of the model, particularly if you're interested in some of those cognitive vulnerabilities I mentioned earlier. And so I listed out some examples of psychometrically sound self-report scales that are frequently used in the literature to understand things like anxiety sensitivity or intolerance of uncertainty. This is by no means a fully endorsed list of the absolute best measures for all of these constructs. I would use your own gut as psychologists to engage in assessment to find the tool that best reflects what you feel is psychometrically sound and valid. But we do encourage folks to use some self-reports, maybe at the start of therapy and then periodically throughout, to make sure that we're able to assess and then track changes in some of these underlying vulnerabilities. And then finally, while assessing avoidant coping, you want to look for cognitive and behavioral responses or reactions to emotional discomfort. And in many ways, it can be sort of easy to start to find these coping strategies because oftentimes those are what lead to the impairment that's causing people to seek treatment to begin with. So these could be things like avoiding social interactions, drinking alcohol in order to relax, repeatedly washing hands for hours per day, or finding it difficult to stop worrying. Lots of times when people come in and you ask them to share their presenting problem, they're giving you examples of the avoidant coping that they're engaging in that's causing problems in their lives. So again, to assess for some of these things, we would recommend just asking some open-ended questions. And as I said before, avoidant coping is really probably the most idiosyncratic aspect of this model, and it can look so many different ways for so many different people, and it can be really different or difficult for people to recognize avoidant coping within themselves. And so it can take a lot of time in therapy before people start to recognize maybe that thing that I'm thinking or that thing that I'm doing when I feel a particular emotion is actually avoidant. And all of that is to say that you're not going to get a comprehensive picture in the first session, but it's still good to start that conversation by asking questions like, do you tend to avoid or put off doing things that bring up a strong emotion or where you think that you might feel uncomfortable? Do you sometimes cope with uncomfortable emotions by distracting yourself in a certain way? I think really the best way to ask these questions, the most comprehensive way to ask, is basically to get a sense of, are there things that your patient is doing that they wish they weren't doing because of uncomfortable emotions? Or are there things that they're not doing that they wish that they were doing because of uncomfortable emotions? In assessing avoidant coping, it's important to consider both the function and the consequences of these strategies. And the reason for that is because the same behavior could be helpful or unhelpful for different people or in different contexts. So for whatever behavior you want to target and change, you want to think about what's the function of the behavior and what are the consequences of it to get a sense of the extent to which it's maladaptive or would be helpful to change in therapy. To get at the function of an avoidant coping behavior, we want to ask questions or at least think to ourselves about, why is the patient engaging in this behavior? When they do this thing, what happens to the emotion that they're perceiving as aversive? And what's the payoff or what's the reward? What are they getting out of engaging in this behavior? In terms of avoidant coping, usually we're engaging in behaviors to get rid of an emotion, distract from an emotion, produce some level of comfort. And if that's the case, then we might consider the extent to which that coping strategy might be maladaptive. Then we want to think about the consequences, which is really where an understanding of adaptive and maladaptive comes in. So we want to consider, what is the impact of repeatedly relying on this behavior over time? Is this impacting your patient in terms of their relationships or their work or any other aspect of any other domain of their life? We want to consider, is the behavior consistent with their values? Is it stopping them from accomplishing particular goals? And then finally, maybe the trickiest one to assess is, does engaging in this behavior reinforce any maladaptive beliefs about emotions, going back to that cycle that feeds back into aversive reactivity? So I wanted to give some examples of how we can think of the function and the consequence of different behaviors that could be conceptualized in some cases as avoidant coping. So first, there's a behavior of avoiding meeting new people. This could have a lot of different functions. This could be a behavior that somebody with social anxiety might want to change. It could be a behavior that somebody with depression might want to change. It could be a behavior that somebody with body dysmorphic disorder might want to change. And from person to person, the function could look different. But for example, for somebody who's avoiding meeting new people, one function of that could be that avoiding meeting people prevents possible negative judgment from those people. From a strictly emotion-focused perspective, we might actually say, sure, the function is to avoid negative judgment, but the root is to avoid the anxiety associated with anticipating judgment or the shame associated with perceiving judgment. The consequence for a lot of folks who are avoiding meeting new people for emotion-related reasons is that we miss out on opportunities to enrich our lives, and it maintains that fear of judgment over time. Another example is perfectionism. So in some cases, the function of perfectionism is to avoid imperfection or to avoid failure. And again, from a more emotion-focused perspective, we might say that really the function is to avoid the guilt or the shame that might be associated with the perception of failing to live up to a standard. The consequence of perfectionism is it requires a great deal of effort to maintain perfectionism over time. I'm a graduate student, so I understand that. And the more we engage in perfectionism, it maintains this unhelpful belief that imperfection is unacceptable. And we might continue to hold false ideas around how high the standards are compared to where they really are without really testing it out. And then finally, another avoidant coping behavior is worrying about an upcoming situation. The function of that could be providing a false sense of certainty or a false sense of preparedness over something in the future. Usually there's some avoidance of actually problem solving and the risk that could be associated with problem solving. Maybe from an emotion focus, there's avoidance of the sadness or shame that could come about if you actively problem solved and failed to do so. So people can stay stuck in this sort of anxious worry state. The consequence of worrying is that there's less time spent on valued activities. And again, it maintains this unhelpful belief that the more we worry about things, we're able to actually prevent or predict negative outcomes. So now I'll just take a little bit of time to talk about how this applies to treatment, particularly in the context of the unified protocol, which is the therapy that Dr. Barlow and colleagues developed years ago that we've been continuing to refine over time and to test in different populations over time. So the unified protocol is a modular transdiagnostic cognitive behavioral intervention that really focuses on emotions and our patients' experiences of emotions. And the goal is to try to modify that neuroticism that I was describing as the central feature of our functional model earlier on. In the UP, there are 8 modules, 5 of which we consider to be the core modules that bring about therapeutic change. These are mindful emotion awareness based on mindfulness, cognitive flexibility, which is similar to cognitive restructuring. We ask people to start changing their emotional behaviors or altering patterns of avoidant coping. And then we do some exposures. They can be irrespective, so targeting uncomfortable physiological sensations, or we offer emotion exposures that could be situational or imaginal to give people the opportunity to process difficult, otherwise avoided emotions. In the UP workbook, we include a case formulation tool that clinicians can use to try to put all of this stuff into practice. So on this case formulation worksheet, as the therapist, you want to think about what are the patient's primary presenting problems, and then you want to try to jot down what you've learned about them in terms of those 3 steps of the case formulation tool. What are the strong and comfortable emotions that they report, and in what contexts? In the box next to that, how would we describe their reactivity to their emotions? And then in the box underneath that, we think about what have we learned about the strategies that they rely on to avoid or minimize those uncomfortable emotions. And we can think about them in those different categories. And then finally, you want to consider the ways that we might be able to apply each of the skills inherent in the UP to help change your patient's relationship with uncomfortable emotions based on what you learned from the formulation. So applying the case formulation, I think we might be a little bit low on time, so I might skip over this one, but essentially this slide is just talking about some of the ways that we might apply each of the core skills to try to reduce the frequency or intensity of negative emotions in particular situations, to enhance a sense of non-judgment around oneself, around their emotions, and to alter some of the patterns of avoidant coping. I wanted to also make sure that we talked a little bit about outcome assessment because we find that to be a really crucial aspect of any good successful therapy. It's really important to do assessment at the start of therapy, as I was saying before, as well as periodically throughout it, just to make sure that you're chasing the right thing or you're going about intervention the right way. So in the UP, in the workbook, we include a couple of brief measures. There's an anxiety severity and interference scale and a depression severity and interference scale. And we usually have all patients doing the UP complete both of those scales once a week. They capture past week severity and associated interference with various emotional states. So like I was saying, one of them is for anxiety, one's for depression. We also offer some other questionnaires that are essentially the same as the anxiety and depression ones, but you can substitute any other problematic emotion. So if your patient is particularly struggling with guilt or with anger or with positive emotions, you can substitute those emotions into these brief 5-question measures and also track changes on those fronts week to week. And as I mentioned before, if there's a particular aversive reactivity vulnerability, like anxiety sensitivity or experiential avoidance that you find is particularly salient, you can assess that at the start of therapy and then periodically throughout as well. So here's just an example of, this is real data from somebody who did one of our big RCTs in 2017. And this is that person's OASIS and ODSIS, or anxiety and depression, symptom and interference scores that decreased over the course of 16 sessions of the UP. And it's really powerful to see that, and we find it therapeutic in and of itself to be able to graph out those scores and show them to our patients week to week. So in summary, really focusing on these shared transdiagnostic mechanisms is a promising approach to understanding the emotional disorders. And given the emphasis today on assessment, I wanted to make sure that we talked about assessing those mechanisms at the start of therapy, either through interviews or through self-report scales, and then continuing to monitor them over treatment. And then I just wanted to briefly acknowledge some of the other folks in my lab. So we are the TrendUp Lab. This was a new name that we gave ourselves, I think last year maybe. The Transdiagnostic research on emotions, neuroticism, and dissemination with a unified protocol. So we're led by a great team of professors, Dr. Dave Barlow, Dr. Todd Farchione, and Dr. Liz Eustace. And then I have some really brilliant colleagues who are fellow graduate students, Julianne Wilner-Turpak, Brittany Woods, Nicole Cardona, and Maya Nofal. I also am putting a shameless plug for our Twitter accounts in there. I'm trying to cultivate a greater presence on academic Twitter. So I have a Twitter account there if you're a Twitter user, and the Unified Protocol has a Twitter account as well, so that folks can stay up to date on the latest research about applications or effectiveness of the UP, as well as opportunities to train in the UP by attending a workshop or by receiving consultation or supervision. And then just three citations that encapsulate everything that we talked about today. There's an article coming out in press very soon that describes the functional model that I was talking about, a chapter that describes case formulation more broadly, and then finally a book that Dr. Barlow and Dr. Shannon Sauer-Zavala at University of Kentucky just released this year. It is the book on neuroticism, and if you have any interest in neuroticism and emotional disorders, it's definitely a must read. And so I would love to now just have a more open-ended chat about any questions that have come up about things.
Thank you very much. Okay, I'm going to stop the recording. Okay.